Okay, so the thing is, luckily with the endocrine system, there isn't a lot of diseases and disorders. And the medications, I feel like in this chapter are some of the most commonly asked medications and disease topics besides all of the cardiac, because cardiac is like, the leading cause of death for a lot of people in America and a lot of other countries. And diabetes is one of the most growing diseases that people have. So, luckily, this chapter isn't too much. And I actually, for the seniors, added in an extra two diseases that I think are important that aren't here, like in our original notes. So, this kind of has something extra if you'd like to have it after. But the interesting thing is the first thing I want to kind of go over is the thyroid hormone because you're going to see with the levels that when it comes to a certain disease, you would think one would be lower or higher, or all would be low in like hyperthyroidism or all high and hyper, but it's actually not like that. So we'll definitely get into that. But I kind of just want to talk about like there's three different thyroid hormones, the thyroid stimulating hormone, and then we have T3, T4, and we have calcitonin. So calcitonin is something that the thyroid releases in response to high calcium levels. But remember, it's that parathyroid hormone that controls the calcium levels. But we also have a hormone in the thyroid that helps control levels if calcium gets too high. And interestingly enough, iodine is contained in a thyroid hormone. That's why sometimes with medications, we have to be careful with iodine. Okay. So, just to recap, like I said, there's a lot of different levels with thyroid, and there's a lot of diagnostic thyroid tests. So, personally, I've never seen a professor ever ask about the levels of T3, T4, thyroid stimulating hormone, and all of that. But you do need to know at least how they work in terms of the disorders, which will come up. So we have the thyroid stimulating hormone, and that simply means we are stimulating the thyroid to release certain hormones, okay? So those TSH concentration is the primary screening test for thyroid function. So we do a TSH level to know, okay, what's going on with their thyroid. And that could be really important on a patho quiz or even on the NCLEX when thinking about, okay, right, if I'm trying to rule out in a case study, if they have a thyroid problem, I'm going to want to measure those TSH levels. Then we have T3 and T4. They are other hormones that are secreted as a result of TSH being secreted. So that's why we focus on these three major hormones when we think about the thyroid. And we want to measure those because those levels are also going to tell us things about thyroid function and thyroid disease, okay? Is there anything that any of the seniors would want to add about any of these tests? I've never really seen any of them really be asked. Is there anything else here that anyone would want to add? No, that's okay. But like I said, I wanted to mention iodine because, like I said, thyroid does have a connection to iodine. So if you have an iodine or shellfish allergy, you need to be really careful, okay? Because with patients with thyroid dysfunction, having an iodine allergy can actually be really, really bad for them because they might not be able to go through certain tests. Because sometimes they might give like reactive iodine to someone to kind of test those thyroid levels. But if they have an iodine or shellfish allergy, they might not be able to do that. So that's why we have to be careful because iodine has a relationship with thyroid hormones because iodine is in thyroid hormones, okay? So we have to really be careful with that when we're testing our patients for thyroid function. So there's hypothyroidism and hyperthyroidism. So hypothyroidism is high TSH and low T3 and T4, which is pretty interesting because you would kind of think they would all be low, but they aren't. And I think the thyroid stimulating hormone needs to be higher, so I think the other levels can counteract and be lower. Vice versa, I think the thyroid stimulating hormone needs to be lower in hyperthyroidism to increase the levels of T3 and T4. But regardless, those are some of the things that you would need to know. Like if I'm looking at lab values and you see they tell you that the TH value is high, but the T3 and T4 are low, then I know, okay, I'm talking about hypothyroidism. So you know when it comes to these thyroid diseases that the values in the labs are a little different. It's not all low or all high. So that's why even for patho, I want you to know this, or even as a senior, when we get those exams on the NCLEX about thyroid diseases, do we know how to recognize the lab values and what they mean? So if someone has hypothyroidism, we're going to have increase in thyroid stimulating hormone and a decrease in T3 and T4. So if we have a decrease in T3 and T4, now we know we're talking about hypothyroidism. And I kind of like to think about these as polar opposites. So we have mental and physical sluggishness, myexedema, coma, somnolence, I don't know how to say that word, decreased cardiac output, bradycardia, constipation, decreased appetite, hypoventilation, cold intolerance, coarse, dry skin, hair and pallor, and weight gain. So I like to think of hypothyroidism as kind of similar to the parasympathetic stimulation because think about all the symptoms, right? There's bradycardia, there's constipation, there's a decreased appetite. Everything seems to be slowed down. So I like to think of hypothyroidism as the slowed down version of everything. Everything slows, you're sluggish, you have no appetite, you don't like the cold, and you have weight gain. Whereas with hyperthyroidism, it's the opposite. And myexedema, coma is something that's going to become really important to monitor for with patients who have hypothyroidism. So mental status is going to be really important for looking at these patients. Whereas with hyperthyroidism, everything is stimulated, right? So we have that decreased TSH, but we have an increased T3 and T4. So we have restlessness, irritability, tremors, thyroid storm, which is basically like your heart rate is really high and this patient's like really anxious, and any sort of stimulation can trigger that even more. They have insomnia, whereas people with hypothyroidism, they're more sleepy, right? Hyperthyroidism, they have increased cardiac output, tachycardia, whereas it's the complete opposite for hyperthyroidism. These patients have diarrhea, increased appetite, dyspnea, heat intolerance compared to cold intolerance with those hypothyroidism patients. Hyperthyroidism, their skin is more thin and silky and flushed compared to hypo, where it's more coarse and dry, and we have weight loss. So I like to think of them as polar opposites. So hyper, everything is stimulated. So that's why they have the weight loss, right? And their skin is like really thin and they have all this heat intolerance and they're like really jumpy. But with hypothyroidism, they're more calm and tired and everything is slowed down. So that's the difference between those two, hypo and hyperthyroidism. They're complete opposites. So I think if you are able to know one, you know the other. But the priorities in these two situations become the myexedema, coma for hypothyroidism and thyroid storm for hyperthyroidism, as these are emergencies. Now, can anyone tell me the medication that we give to someone who has hypothyroidism? Okay, so that medication is called synthetic levothyroxine, which is basically a hormone that you give to a patient who has hypothyroidism, which is also called Hashimoto's disease, and it actually causes hyperthyroidism effects. So the side effects are tachycardia, insomnia, increased appetite, and tremors, which are mimicking the symptoms of hyperthyroidism because synthetic levothyroxine is basically giving them thyroid hormones to increase their thyroid levels. And sometimes it's called levothyroid. And patient education is to take this medication on an empty stomach in the first thing in the morning, because remember, we said in hyperthyroidism, or the symptoms of it, they have diarrhea, right? So if we take this medication with food, there's a risk of GI upset. So we're going to take this medication on an empty stomach. That's really important. So for your farm test, if I have a patient who has hypothyroidism, the expected adverse effects include that tachycardia, insomnia, all of those kind of like sympathetic, like stimulation effects, tremors, insomnia, increased appetite, and important patient education. I want to take this medication, or I want my patient to take this medication on an empty stomach in the first thing in the morning to prevent any sort of GI upset. Okay, so that's an important medication in the endocrine system for hypothyroidism. Now, we also have Myexedma coma, which is a life-threatening, very rare condition that is due in part of having hypothyroidism. It's so severe that they come into a comatose state. They're hypothermic, they're unconscious. It's like CNS depression at its extreme, okay? So you have your low temperatures, they're not breathing properly, they have depression, they have decreased cognitive status, they're lethargic, they're confused, they're tired, they're bradycardic. This is like CNS depression at its finest, okay? So that's why with these patients, anybody who has hypothyroidism, we really need to say, okay, I need to watch out for their mental status changes. I need to see what's going on, their breathing patterns, right? Are they having any sort of cognitive changes? Are they becoming more slowed and fatigued, right? Because that can be an issue. They can become unconscious and go into a comatose-like state. So for these patients, we give them Synthroid, but through a drip IV, so that the medication can go through quickly to reduce the effects of the comatose state. But if the symptoms start showing, like, because we said Synthroid can cause those sympathetic or those hyperthyroidism-like effects, we don't want to stop the medication if they have them, but we just want to decrease if those manifestations occur, because they need the medication to increase those thyroid levels so they can get out of the coma. So we don't want to stop it, And the same sort of thing, right, when they are more awake and they're back to, a normal level of functioning, we're going to teach them that same thing, where we're going to tell them take it on an empty stomach to prevent any sort of GI upset, okay? So, right, we can also manage hypothermia that they get from the Myexedma coma by giving them a warm blanket. We don't really like heating pads because it can hurt the skin more, okay? And think about it, right? We want to have rest periods because they were just fatigued and they came out of this comatose-like state, right? If it's going to cause respiratory depression, we want to monitor the O2, okay? We also want to watch cholesterol levels because they might have complaints of some sort of chest pain, and that can be from the coma, the myexedema coma. We want to turn and reposition them every 2 hours. Why? Because they're in a comatose state, right? And then they can't really move themselves. So we want to make sure we're doing something to make sure they don't have any sort of skin breakdown or skin injuries or anything like that. Also, we want to look at EKGs, right? Especially after we give that thyroid replacement therapy, because it's going to increase everything, and it could increase the heart rate so much where there's that potential tachycardia and even maybe an arrhythmia. And because they just had a coma, we don't want to give them sedatives because that can induce the coma, because they have hypothyroidism. And because if these if this is a disease or an illness that affects weights, we always want to take daily weights for these patients. So that is why with these patients, we want to look at weights. There's a lot of nursing management, and it's going to come back in your med-surg class when you do endocrine, but it's good to get this information in your head now. And for my seniors, it's a good little review of things if you don't remember. I don't remember everything, but it's nice to go through my notes and try to remind myself as much of the information as I can. Now we have hyperthyroidism, which is also called Graves' disease. Now, does anybody remember one of those symptoms in Graves' disease that kind of lets you know that they might have hyperthyroidism? I'll give a hint. It has something to do with the eyes. So the eyes bulge out of the head. It's kind of like one of those cartoons, when the eyes get like really big in the cartoons and they start popping out of their face. Well, in Graves' disease, we actually have the eyes popping out of the head. Um, and for anybody who came who's a senior, please put your SFC ID number into the chat, just the seniors. There are some guests here. We have some juniors who want to learn about endocrine here with us today. But moving on with the rest. So like I said, hyperthyroidism, we're thinking about Graves' disease, and one of those common manifestations includes those eyes bulging out, right? And I said a problem is that we have an increased risk for thyroid storm when they have hyperthyroidism. Other things they can get is goiter, which I don't remember what that is. If there's any senior who remembers exactly what that is, I thought it had something to do with the neck, but someone can change me that, like tell me if that's different. And I knew that they have the large bulging eyes.
The goiter, yes, they have a large throat area. It's very like it looks very swollen and shiny. The
Yeah,
neck
yeah.
area, so yeah.
That I remember. I just didn't remember what goiter was because that word just didn't click. But yeah, they have bulging eyes. It's like a classic symptom. And so the issue with Graves' disease or hyperthyroidism is that we have this increased metabolic rate. That's why I said it kind of mimics that sympathetic symptom and oxygen consumption, okay? So it's like I said, increased sympathetic nervous system response due to an overproduction of thyroid hormone. Because, like I said, those symptoms sort of mimic those sympathetic nervous system like responses. So there's only slight differences, whereas in hyperthyroidism, they have an increased appetite, whereas in hypo, they have a decrease. But so, medications, I've mentioned this before, but beta blockers is one of the drugs that we can use, like propranolol, for hyperthyroidism. I'm not exactly sure why, so someone could try explaining that, but I think it's just because of where it works that it can help control some of those sympathetics, not exactly like affecting the thyroid levels, but because beta blockers are anti-sympathetic nervous system stimulants, I think that this drug is being used to counteract those sympathetic effects and help prevent a thyroid storm. Other drugs that we have is I don't know how to say polypyrethrosil. Let's just go with that. And it blocks that T4 and T3 because remember, we said the T4 and T3 are elevated in hyperthyroidism, but it's that thyroid stimulating hormone that's low. So we give this particular medication to block the T4 and T3 from increasing. We also have methimazole, which inhibits the synthesis of a thyroid hormone, which is another way of blocking it. We can give sodium and potassium iodide, or we can give dexamethasone or steroids. And like I said, iodine is contained in the thyroid stimulating hormone. And that's why in thyroid hormones and iodine, we got to watch out for those shellfish allergies because we really have to be careful with that, especially when it comes to medications. But one of the most popular ones for hyperthyroidism that I'm aware of is propranolol and the iodines. Does anybody have anything else that they'd want to add for hyperthyroidism or Graves' disease? No. Okay, that's okay. So we have thyroid storm, which I said is it's a very, very severe form of hyperthyroidism. Okay. So basically, it can be fatal. So they're like overly stimulated. So if I said that a myexedema coma in a hypothyroid patient is CNS depressive like effects, right? Like hypothermic, bradypnea, bradycardia, all of that stuff, then it's going to be the opposite in a thyroid storm. We're talking about hyperpyrexia or a really, really high fever greater than 101.3. We're talking about extreme tachycardia, like above 130, right? Exaggerated symptoms of hyperthyroidism. So increased weight loss, increased diarrhea, cardiovascular palpitations, things like that. They're going to have anxiety and restlessness. With these sorts of people, they may even have delirium or psychosis or an altered mental state. So with both of these, we really have to watch in myexedema coma and thyroid storm for that mental status changes, especially if the thyroid storm patients start to get confused or maybe even see things, then we're having a problem. Whereas in the comatose state, I don't know what I just said right now, but in that state, that patient is more getting confused and lethargic. So that's kind of the difference in the mental status changes, but it's the complete opposite. So we have bradycardia there, we have tachycardia here, we have hypopyrexia here, we have hyperpyrexia in thyroid storm. So everything is just polar opposites of each other. Nursing management, make sure they're taking their medications. Important, providing a calm environment. Why would we want to provide a calm environment to a patient who has hypothyroidism or in a potential hypo or a thyroid storm? Well, that's because if they're overly stimulated, right, it's going to be very, very hard for them to decrease those sympathetic responses because their body's already stimulated. So if we're going to increase stimulation in the room, we're going to make their thyroid storm worse. We're going to increase their anxiety, and that's not going to be good. So we want to dim stress, and we dim the lights and minimize any sort of stress that they might get. Does anybody have anything else that they want to add for a thyroid storm? Okay, so like I said, medications like propranolol, we want to reduce the temperature, right? Because in part of that thyroid storm is hyperpyrexia or increased temperature. So we want to take acetaminophen. We want to tell them to take this to help lower the pressure, the fever, so that they have less of those symptoms. Right? We want drugs like propranolol to stop the heart rate, to help reverse some of those sympathetic like stimulation. That's what propranolol is used for, because there's no drug necessarily that's going to sit there and lower all of these. We're going to have to give multiple medications. It's not like in hypothyroidism where we just have, levothyroxine or synthetic levothyroxine. We don't have that here. We have different medications that can be used differently, but we need to get that sympathetic stimulation down. That's going to be very effective in preventing further effects of the thyroid storm. So we also might want to give them sedatives like barbiturates to reduce that restlessness and calm them down. But remember, we aren't going to give a sedative to somebody in a myexedema coma because of those CNS depressive effects. And we don't want to overstimulate the patient. Is there any questions or anything anybody would like to add? Okay. So the next gland that we have is the parathyroid gland. And the interesting thing about this one is that the parathyroid, right, is sort of like behind the thyroid. And the parathyroid hormone regulates calcium and phosphorus. I did mention before that the thyroid hormone does release calcitonin, which is a hormone that decreases calcium levels, but the main gland that helps in reducing or controlling calcium level is the parathyroid gland because it releases the parathyroid hormone. And something very, very important about the parathyroid hormone is that it has a direct correlation to calcium, which means that when you have hypoparathyroidism, you have hypocalcemia. When you have hyperparathyroidism, you have hypercalcemia. But phosphorus levels, it's an inverse relationship. So when you have hypoparathyroidism, you have hyperphosphatemia. When you have when you have hyperthyroidism, you have hypophosphatemia. It's an inverse relationship. And interestingly, the symptoms that you have in hypocalcemia are the exact same symptoms that you're going to have in hyperphosphatemia. And that's because those two work together. So the one that I like to remember, because hypocalcemia is very important, it's the mnemonic cats go numb. So cats go numb is convulsions, arrhythmias, tetanies, spasms, and seizures. So that means these patients better be on our seizure precautions. And what are seizure precautions? Can anybody name a few of them? Well, we need padded side rails on the bed, right? Because if they go into a seizure and they start to convulse, we don't want them to hurt themselves. We want to remove any sort of, if they have like a button or the gown is too tight, we want to loosen it around the neck because they could choke. We want to turn them to their side because they might start choking on their salvation. So we want to turn them onto a side to make sure they don't choke and things like that, okay? And we don't want to put anything in their mouth and we want to protect them, okay? So that's just something that I want to put out there when it comes to seizures, just to refresh in your mind, because seizures is something that can happen. And like I said, the mnemonic cats go numb. Now, does anybody remember when you have hypocalcemia, what the two signs that you see let you know, okay, this person has hypocalcemia? Like, what can we do? What can we test? Does anyone remember what Chosevic sign is? Or I don't know how to say his name, but the Chosevic sign, that one. Well, that's when you tap a person's cheek, it like spazzes, and that lets you know they have hypocalcemia. Or troso sign, I think is how you say the name, where you put the blood pressure cuff on the arm and you press it really, really tight, and it makes the arm like spaz. So those are two signs of hypocalcemia, because hypocalcemia, or when you have low calcium levels, it actually causes like a stimulatory effect. That's why all your muscles start to like spasm and twitch. Whereas with hypercalcemia, it's more sedative. So things are more calming. And that's why you have things like constipation and other things like uh, increased urination, muscle weakness, and things like that. You also could have kidney stones because too much calcium, you can get calcitonin type stones that can get into your bladder and form, and those are a form of kidney stones because there's multiple types of kidney stones, and one of them can be formed from calcium. But those are just some important facts about hypo and hypercalcemia. And like I said, for these things, right, I'm going to give calcium to my patients who have hypocalcemia, and I'm not going to give calcium to patients who have hypercalcemia because it doesn't make sense. Things that you could do, right, is you're going to monitor for constipation and things like that for my hypercalcemic patients, and you're going to treat whatever is causing the hypercalcemia. Whereas with hypocalcemia, you want to give them things like calcium gluconate or anything that can raise those calcium levels. But like an interesting point is phosphorus, high phosphorus or hyperphosphatemia is going to be the same exact symptoms as hypocalcemia. And hypercalcemia is going to have the same exact side effects or presenting symptoms as hypophosphatemia. And that's just because of how they work in the parathyroid hormone. So basically, you understand what hyperthyroidism is, and you understand what hypothyroidism is. You know what hyperparathyroidism is, or at least what it causes, right? That increased calcium and decreased phosphorus. So, like I said, hypercalcemia, we're thinking about the kidney stones, the increased urine, the muscle weakness, yada, yada, yada. And we're thinking about low phosphorus levels, and low phosphorus levels mimic high calcium levels, so not much difference in that, right? Constipation, the bone pain, kidney stones, all of that. It's the same thing, okay? So sometimes you might want to give someone a parathyroidectomy to help revert the symptoms of hyperparathyroidism. Maybe you could try with other things, but it really just depends, right? But regardless, if I'm going to give them a parathyroidectomy or if I'm going to have a surgery in their throat area, what is my priority to watch out for post-operatively? Airway, right? Because if I'm going to do a surgery near someone's throat, there's always that issue of maybe blood getting into the throat and the trachea, right? So we need to make sure we have a patent airway. That's going to be our priority, right? And they're also at risk for things of developing potential kidney stones. So we want to watch out for things like that, okay? And we want to give them fluids because hydration and fluids helps with those kidney stones. And we don't want them to be bed rest because that increases kidney stone formation. And we want to restrict calcium in the diet because the body's still trying, to compensate and figure out, like, we just took out the parathyroid tissue, so the body's still adjusting. So we don't want to do anything to aggravate it. And corticosteroids can also be used in emergencies to lower calcium. And I think that's because of where it works in the body. It can actually fight for receptor sites. Hypoparathyroidism, like I said, it has symptoms of hypocalcemia, and hypocalcemia has the same symptoms as hyperphosphatemia. So I don't have to repeat the manifestations because it's the same thing. So if you know that, you already know what that disease is, what it does, and how to treat it. So with all of these, like I said, with hypo, we're talking about low calcium levels, high phosphorus. So we're going to reduce phosphorus intake, which is actually in beans and milk. And chocolate has phosphorus. And for calcium, we want them to increase calcium supplements. So we might be careful, maybe not so much with milk, but we might do other things like cheese and, what are the other products, calcium supplements. But it just depends, on the provider's orders. But regardless, the goal is to increase calcium and decrease phosphorus. And you could decrease phosphorus simply by just increasing the calcium levels, because then the body's just going to sort it out. So I don't need to go into too much of the management because we kind of already talked about that. But another important point that I wanted to add, is that we want to have quiet environments, because when they have hypocalcemia, we're talking about stimulation. So it's still the idea. Anything that causes stimulation or stimulatory like effects, we want a calm environment, okay? Now, also, we can give them like a thiazide diuretic to help decrease the urinary calcium secretion, because thiazides like to retain the calcium. So it's very good to give them a thiazide diuretic if they need it, so we don't remove all that calcium level, and we could help treat the hypoparathyroidism. And as I mentioned before, milk products are high in calcium, but they're also high in phosphorus. So it might not be so good to have milk products with someone. So it's interesting. It's a weird play, but milk is in phosphorus as well. So diabetes, we're gonna be talking about some really important diabetic medications coming into here, and some important points that I think might be on some of your pharm exams coming up. And for the seniors, every time I've been doing practice tests, I've been seeing at least diabetes once. So it's definitely somewhere. But does anybody know the difference between type 1 and type 2 diabetes? So type 1 is usually hereditary. You're usually born with this one. And the thing with this is that you usually have no insulin production. You are just not able to produce insulin, okay? And a complication of type 1 diabetes is something called diabetic ketoacidosis, is when the sugar level gets so out of control because of that, because of the body's ability not able to produce any sort of insulin, is when we get a diabetic ketoacidosis crisis, okay? But they're usually born with it and they're usually thin and they have a lot of weight loss, okay? So basically, those beta cells in the pancreas are the reasons why we have insulin and they're not working at all. Those beta cells are not doing their job, okay? So we have diabetic ketoacidosis, which is like a metabolic emergency, okay? And it comes from a deficiency of insulin. They can't produce it. And they have something about this disease that's characteristic of it is that they have fruity acetone breath and they have ketones in their urine, okay? So, like I said, it's an emergency with a blood glucose level over 300. It is scary. And if it helps with diabetes, common 3 symptoms are the 3 Ps: polyuria, polydipsia, and polyphagia, which is increased urination, increased thirst, and increased hunger. Other things with manifestations with diabetic ketoacidosis, like I said, that acetone or fruity breath would be something, ketones, and Kussmaul's respirations, which is not a good way of breathing, okay? And things that we want to give them, which we're going to get into the medications, but regular insulin, because regular insulin works via IV, so it's going to be quick. It is the only insulin that works via IV. So it works very quickly and we can give it as an IV medication. That's why we give it during diabetic ketoacidosis. We also want to monitor blood sugar levels. Why? Because their issue is that they don't have enough insulin. So their sugar levels aren't that great. And right now, if they're in diabetic ketoacidosis, their sugar levels like over 300. So we want to watch that. It can also cause electrolyte imbalances because of the potential of them having nausea and vomiting as a result of having such a high sugar level. So we want to replenish those by giving normal saline and other fluids, right? But not via the mouth. We want to keep them NPO. Why? Because they're nauseous and vomiting. And most of the time when people are nauseous or they're vomiting, they don't want to take anything in my mouth. So it's best to not do that because they might throw it up anyway. We want frequent blood work to like look at everything, right? To see what's going on with those values, see what's going on with those electrolytes. Look at the urine because of the ketones, look at the renal function because diabetes in general can cause the kidneys to also go bad. So we have to look at renal function when our patient is a diabetic, even if they're not in diabetic ketoacidosis. And like I said, it's a very, very, very severe thing that we want to treat. With type 2 diabetes, you usually acquire that from lifestyle habits. It's where your insulin levels are just not working as properly, but they still work. You know, this could be corrected with at least diet and lifestyle modifications. And type 1 diabetes, there's no chance in correcting it whatsoever. And usually these patients have obesity. Okay, so there's a decrease in insulin or insulin resistance, but there's no insulin deficiency like in type 1. Oral anti-diabetic agents may improve the blood sugar levels. The most important one, or at least one that I know is commonly asked, is metformin. Okay, metformin is an anti-diabetic medication, meaning that it lowers the blood sugar levels. Okay. Now, does anybody remember why we don't want to give metformin if a patient is going to go for a procedure with an IV contrast? It's because they're going to react with it. So it's going to cause a reaction with the IV contrast, and that is not good. So we always tell our patients if they're going to go do something and they're going to get an IV contrast, it can hurt the kidneys. So we tell them to stop taking metformin. They'll call the provider, tell them I'm having a procedure. Doctor would tell them when to stop the metformin before that with the IV contrast, or else they can have kidney damage because metformin can damage the kidneys. It is an anti-diabetic agent that helps lower blood sugar levels. But if they have a procedure with IV contrast, we need to hold metformin until after that procedure because of potential kidney damage, okay? So something that they can get if they have type 2 diabetes that they can't get if they were a type 1 diabetic is something called hyperglycemic hyperosmolar syndrome, which is another way of there's no ketones, there's no fruity acetone breath, there's none of that like that. They have the 3 Ps, they have nausea and vomiting, but it's a lack of insufficient insulin that gets so bad that their sugar also gets really high, and here's a problem. Another place where we give that regular insulin via IV, because it's the only insulin that is given IV. Same thing, even when you're thinking about the anti-diabetic medications and you're going through pharmacology, think about it. If this is an anti-diabetic medication, I'm lowering my blood sugar, I must be constantly monitoring blood sugar levels, okay? What else? Electrolyte imbalances can be caused as a result of these different diseases because of the nausea and vomiting that you can get in hyperglycemic hyperosmolar syndrome, or HHS, and diabetic ketoacidosis. So we might have an electrolyte imbalance. So we want to watch blood values, right? Adequate hydration, right? In the nausea and vomiting, they need to be constantly hydrated and correct any electrolyte imbalances. Like I said, the most important things with diabetes is things like polyuria, polydipsia, polyphagia, tingling and numbness in the hands and feet, right? Increased risk for infections, okay? Visual changes, because something else that diabetes can cause is something called optic neuropathy, and it can affect the eyes, okay? So we need to be careful with our diabetic patients because all of their sugar levels can affect their eyes. Now, does anybody remember any patient teaching as for why we tell a diabetic patient to always check their feet every day? So we tell them to check their feet every single day because they have numbness and tingling in their feet. They can't feel sensation. So sometimes they might cut themselves and they might not know they cut themselves. So they must check their feet every single day. Okay. Now we're going to get into some of this medication management, right? So when we go into the medication, before we get into that, right, some ways that we're going to try to do things is trying to normalize insulin and blood sugar levels by watching the diet, trying to get them to exercise. We want to do everything that we can before we give them medications, okay? Then we're eventually going to give them medications. And when we do, they're going to be anti-diabetic agents or agents that are going to lower the sugar levels, okay? And for diet, think about it, right? We also want to make sure that when we're talking about diet and things that our patients, we want to think about things that have things low in sugar. So we need to be careful with the sorts of foods and things that we give to our patients, okay? And something else that we give for diabetics is we put them through I think it's every 6 months, an A1C, a hemoglobin A1C level. I think it's 6 months. Someone can correct me. But that's where we check the level to see if it's greater than 7%, because if it is, then they're not maintaining their diabetes and we need to take more actions to lower the sugar levels. It's like a check to make sure if they're doing okay. Okay, so we want them to increase things that are fruits and vegetables, right? And things that can help lower these sugar levels, right? Because drinking juices might increase sugar. So we want to try to tell them dietary measures that's going to help lower the sugar levels, okay? Now, I want to talk about, most importantly, medications that affect diabetics and different types. So insulin therapy, I already know is going to be on your exam or any exam or even the NCLEX, but we have different types of insulin, okay? And you need to know what they are, if they're rapid acting, if they're short acting, if they're intermediate, and if they're long acting. Like I said, with type 1 diabetics, they need insulin every day. So they have a different form of getting insulin than someone who might be a type 2 diabetic. But regardless, these are the types of insulin. So we have rapid acting, and that includes Lispro, Aspart, and Glucine, okay? These act in 10 to 15 minutes. So we must give it with food. If your question talks about an insulin medication or a medication that you're giving for a diabetic, and it says something about tell the patient to take it with food, I would pick that answer. Because insulin will drop so quick. And if they don't have food there, the sugar's going to get so low that they might pass out. And that is not good. So with our rapid actings like our Lispro, our Aspart, our glucine, they must have food. Short acting, regular insulin. It's the only one that is IV. So regular insulin is a short acting, right? It takes a little longer to work than rapid. It's used in DKA because of the IV form or the HHS, right? It's also a medication that we need to take with food, right? Or something there with sugar in it, right? So they might want to give them a solution of maybe lactated ringers as well, something with sugar in it, because of the fact that if they don't, the sugar will get too low, not good. Then we have intermediate acting NPH, which can be given with other insulins. So here's the thing, with medication administration, with these type of medications, you're always going to want to, you're going to mix the medications, right? You're going to shake them. But the thing is, you're going to want to do, please someone correct me if I'm wrong, but it should be the regular insulin first and then the NPH. I don't know if anybody else has something different for that, but I remember you have to give regular insulin first and then you give NPH. Lastly, we have long acting like Lantus, Glargine, or Detamir. I don't know how to say that one. But it's a once a day dose, and we do not mix this one with other insulins, okay? This one we don't need to have food there, but we will not mix this medication with other insulins. NPH, yes, we can mix it with other insulins, like, regular insulin. And if we do that, like I said, it's the regular insulin first, then the NPH, okay? So those are the insulins. I know that's going to be on your exam. So I would know this. I would know which ones I take with food, which forms, and their names. Okay. So complications of this include allergic reactions, and very important teaching point is that they must rotate the sites. That could be on your pharm test because medication administration is a part of pharmacology, right? And that could be any question on any test. So we need to rotate the sites that we give insulin because they can get something called insulin lipodystrophy, which is kind of like lipid deposits that can kind of form. So you need to change the site, okay? You need to move around where they're giving themselves injections, okay? And sometimes they might get morning hyperglycemia as a result of taking insulin therapy. Okay, so we also want to tell them with insulin, right? They're all personalized, so you don't share them, you don't give it. They're subcutaneous, right? So that means it goes on the side of the arm or maybe on your stomach, right? And there's different types of insulin pens, okay? And here's another thing that comes with diabetics. If they have a hypoglycemic crisis, meaning their sugar gets so low, it's like 30, let's just say. They're confused, they're dizzy, they're diaphoretic, they could pass out, things like that. Slurred speech. I know this because my grandfather had a hypoglycemic episode and had a sugar level of 30, and he passed out, he got confused, he felt weak, and he fell. And he is a diabetic. But in an emergency, when this happens, you must give 15 grams of a fast-acting concentrated carbohydrate. So that includes 3 or 4 glucose tablets, 4 to 6 ounces of juice or regular soda, not diet, regular soda. And report what you have given to the patient, okay? You must retest that blood sugar in 15 minutes after you give that, okay? Now, you could also give them a snack with protein and a carbohydrate as well to eat in the next 30 to 60 minutes, as long as they're not too confused, right? Because they might choke. So if the tablet or the juice, if that works and that glycemic crisis and they're not like, dysphagic or anything, but if they're unconscious and they can't take that, okay? If they can't take the sugar, they can't take the juice, they can't take a carbohydrate snack, what we're going to do is we're going to give them a subcutaneous IM injection of glucagon, 1 milligram or 25 to 50% of 25 to 50 ml of 50% dextrose IV. But that usually it's that IM glucagon that you're going to, hit, give in one of those subcutaneous spots to help increase that blood sugar if they're unconscious. Okay, these are not like traditional medications, as you would say, but these are something that can be tested on farm because it's what you do when someone who has an endocrine disorder, like or a hypoglycemic episode, and if they're unconscious, I'm going to give them an IM injection of glucagon. Okay. So you're going to give them that, or you're going to give them 25 to 50 ml of 50% dextrose IV. So we're going to want to check that sugar, make sure we teach them all about the different insulins, make sure if they're taking Lispro, Aspart, or Glucine at home, because those are oral, right? That they can take, they need to have food there. If they're not going to eat when they're about to take that medication, they better not take that medication because their sugar level might get too low and then they might have a hypoglycemic episode, okay? Like I said, if we're giving metformin to someone, make sure if they're going to a CAT scan with contrast, they do not take metformin because it can cause renal damage. I know that's going to be on your exam or somewhere. I know that. Now, the last two things, I kind of brought this in for the seniors or any sort of patho, if anyone might have that coming up, is like Cushing's disease. And something that I would want to know because it's an endocrine disorder and they might try to be tricky is that Cushing syndrome is caused by hypercortisolism or excess cortisol, and that's excess glucocorticosteroids. So we don't want to give this patient steroids. Actually, steroids can be the reason why someone obtains Cushing syndrome, which is a tumor of the pituitary gland, which is causing an excess production of these hormones, especially cortisol. Okay. So you have things like a moon face, so from altered fat metabolism, skin over the forearms and legs becomes really thin. They have like purple striae or stretch marks, the bone brittling, and that is because if you remember, I told you all about steroid medications. Something that they can cause is osteoporosis. So too much steroids, that's why they say long-term use or using steroids for more than 10 days is not good because you can get delayed wound healing, risk for infections, and also osteoporosis, okay? So it can also cause, I don't know how to say that word. I don't know how to say that H word that I have in orange, but it means hair growth. Okay, they can have excessive hair growth, but the most common symptoms with Cushing's is that moon face, hair growth, the thin forearms, the striae or the stretch marks, and osteoporosis. Okay. And treatment with Cushing's disease, right? Like I said, we're not giving them steroids. Okay, no steroid medications for these patients. Whereas with Addison's disease, Addison's is the opposite. Addison means that the adrenal cortical those hormones are actually reduced. So we have a deficiency of those hormones, which means we're going to have the complete opposite, okay? And we have different hormones that are produced there. But because it impairs ACTH levels, we get no really mineral cortical steroids and no glucocorticosteroids. In other words, we might want to give this patient steroids to help correct this problem, okay? So with impaired mineralocorticosteroids, we have an impaired ability to regulate salt and water. That's why even in Cushing's, we got to watch out for electrolytes because too much can cause a problem. Same thing with too little of our ability to regulate salt and water can also affect our electrolyte levels, right? And also our blood pressure, right? So we need to be careful. These patients have a problem with regulating salt and water elimination. In other words, they pee out everything, okay? They get rid of all of it. And they can't really regulate their sugar levels. So they also have hypoglycemia. Whereas with those Cushing syndrome patients, it's the opposite. They have too much. So they have hypertension and they have hypertension. hyperglycemia because of too much steroid production. Okay, so we have weight loss, and something characteristic of Addison disease is hyperpigmentation. And here you see here hyponatremia and hyperkalemia, electrolyte imbalances. Why? Because of that salt and water problem. Okay, and hydrocortisone is the drug of choice in treating someone with Addison's disease because the hydrocortisone is going to actually help with alleviating some of these symptoms. Okay, it's going to help reduce some of that stress that's being caused to the body, and it's actually going to help revert with the Addison disease. And yeah, is there any questions about any drugs or medications or anything like that? I know, like I said, some of these the types of insulins I know would be on some of your farm exams for next week. So I know definitely go over those and what you do in a hypoglycemic crisis without a doubt. Definitely the medications for thyroid. So there's definitely some good stuff in here, at least to start you, because I don't have access to anything else. But is there any seniors or juniors that have any questions about the topics that I talked about, or is there anything anybody would want me to go over again?